next time we'll know. Okay. This is our guest, Dr. Angela Barbera, and she is with Eye Consultants of Pennsylvania. I think instead of going into a long bio, I'll just say that she's a Vitreo-Retinal specialist, which means she's a medical doctor. And so I've asked her here to talk about and answer some of the common questions I get in the group. So I think, and I have a list here, I'm just going to go, oh, geez, I can't, I am just going to go ahead. Ignore me. Don't look at me. Look at Dr. Barbera. How about that? I'm just going to go ahead and start asking her these questions. And the first one, Dr. Barbera, is what is wet AMD?
So in order to answer that, we have to mention what dry is too. So the way I think about dry macular degeneration, it's the buildup of waste products in the outer layers of the retina, kind of like I tell people, just like age spots on hands, you can get them in the back of your eye. So those are weak spots in the retina. Think of them maybe like cracks on the sidewalk as the sidewalk wears down over the years. Wet macular means that through those cracks in the sidewalk, those damaged areas, bad blood vessels grow. So kind of like weeds in the cracks between the sidewalk. Typically what happens is they grow underneath the retina, and instead of having a nice flat retina, the retina gets elevated and we see swelling and bleeding, and that's
Okay. Out of all the people with AMD, what are your statistics for how many people progress to wet? I've seen so many different ones.
It's tough to say because it has to do with what the individual looks like in terms of how big their drusen are their pigment.
Oh, I mean like a percent.
Is there wet in the other eye?
Yeah.
Well, in general, I would say 90% of AMD is dry macular, whereas 10% is the wet macular.
Mm-hmm. Yeah. Okay. I'm just going to start down the questions. So one of the questions we get a lot of is, if I have wet AMD in one eye, am I definitely going to get it in the second eye?
You don't definitely get it in the second eye. However, you're at higher risk. Again, it depends on what that other eye looks like. If there's large drusen, you're more at risk. If there's pigmentary changes, you're more at risk. So the best person to kind of give you an idea of what your chances are of developing wet in that opposite eye is your retina specialist, just looking at your.
Okay. And a big question is, if I have wet AMD, is it okay to have cataract surgery?
Cataract surgery and wet macular degeneration are separate. So because the cataract is in the front of the eye and the wet macular is in the back of the eye, there's no problem with it. There have been big studies, big reviews, and has not shown that cataract surgery in someone with dry macular increases your risk of turning wet either. I hear my feedback, so that's what I'm pausing about. Sometimes I think cataracts are so dense that it's more difficult to identify wet macular. And so some people may realize that they have wet macular after cataract surgery, but that's not a common thing. They're good imaging these days.
So I've heard people say, or people report that, you know, my aunt so-and-so didn't have AMD. They had cataract surgery, and then their AMD turned wet. Is that just a coincidence?
Yes, that's generally just a coincidence, or as I was saying, maybe the cataract was so dense that they couldn't see subtle bleeding or subtle fluid prior. But it's been studied extensively that there's no correlation between the two.
Okay. I assume that the retinal specialist and the cataract surgeon would coordinate to make sure there's no active bleed at the time, right?
Typically what happens is for my patients that are requiring injections, my preference is to get them a shot like a week or two before cataract surgery. That way, you're well recovered and healed from the injection. And then if they need monthly injections, the cataract wounds have been sealed for a few weeks before I do another injection. In reality, the gauge of the needles that we use is so small that most of the time it doesn't quite matter, but that's typically what I would do.
And somebody asked, is there an issue with, okay, so you have cataract surgery. This is after cataract surgery. You've got a new lens. Is there any problem, any issue with that, with the new lens and having the injections?
Right. The injection that we do is in an area called the pars plana. So it's actually behind the iris or the colored part of your eye. The lens isn't affected in any way by doing the injection.
Okay, Marilyn, if that did not answer your questions, chat at me. Okay, great.
I should have.
You should have. I'm sorry, you said that we're getting some dropouts, I think.
Oh, I'm on.
Pardon me? Do you have another device that's got some audio coming out? Your laptop still running?
I hear it from you.
Because
my laptop is muted.
Okay. I don't have anything else running. I think it's probably just transmission issues. You know, between you.
Yeah, I hear myself speaking.
Yeah. So you've got a delay. Okay. All right. Anyway.
Maybe the Facebook coming through.
Yeah, with you know, we're not connected to Zoom, so it's not related to that. We're just on Facebook now, unfortunately. All right. What would happen, and I have a lot of people who really don't like injections, and a lot of them say, I'm going to quit. What would happen if somebody has active wet AMD and they just say, no more injections?
The concern in stopping the injections is that then the macular degeneration would follow its natural course, which is eventually losing central. Typically, end-stage macular degeneration ends up being possibly seeing the big E or maybe just counting fingers, but having a big blind spot in the center, most important part of your vision.
Yeah, yeah. Okay, this is sort of related to another question, but I'll go ahead. Carol says, my doctor gave me an option to continue shots, but in my case, she doubts they will help. This is after 8 shots in my legally blind eye. I'm not sure if I should continue. Your opinion?
So I think it depends on what a patient's vision is, whether in advanced cases, I'll decide that it makes sense to stop injection. The concern is that if you stop injections, most people, depending on the study, it might be 60% or 70% will recur at some point. If you recur, let's say you have like that big blind spot, there's a possibility that the blind spot gets a little bit bigger. In reality, if your vision is very poor, it might not functionally make a difference. But if a patient is reading 2200, then sometimes I am hesitant to stop because I don't want to see them fall off the eye chart.
So in other words, somebody who is already legally blind, that's what, 2200, 2100, 2200?
20.
Yeah.
Mm-hmm.
So they're already legally blind, but it could recur and get worse. So in some cases,
right, the blind or scarring that then makes the vision get even worse. So yeah. Again, it's an independent decision, but there's certainly cases. Fortunately, I think damage isn't being aided by the injections, and so sometimes I will stop in advanced cases as well.
Mm-hmm. Sharon, I'll get to your question in a minute. Why did the retinal specialist, why do retinal specialists choose, Eylea or Lucentis or Avastin? How do you make that decision as to what to use?
So the story between the different medications is a little bit long-winded, but essentially there was a medication, or when retina specialists were first thinking of how to treat macular, the thought was that anti-vascular endothelial growth factor would help with the disease. So they started developing Lucentis. Other doctors realized that Avastin was another medication we had on the market, and so they just started to use it. So Avastin is made systemically for colon cancer. So it comes in a large vial, but smart ophthalmologists realize that if you take that big vial and you divide it up into little syringes and you inject it in the eye, it works very well as well. So Avastin, that's why that came being used. Lucentis then became actually FDA approved for use in the eye. Avastin is not. And then years later, Eylea became approved, and now newer ones like Betadine and Vabysmo. But in general, when they've compared head-to-head, Avastin and Lucentis, there's not a huge difference in efficacy between the two, and studies between Eylea and Lucentis have said the same. A lot of times, because of insurance issues, Avastin ends up being cheaper because of the fact that it's a compounded drug. So a lot of insurances now mandate us start with Avastin. Avastin is a great drug. It's a miracle drug and works well for a lot of people. So our practice typically starts with Avastin, and then we might change to another one if you don't respond. The way I think about it is it's like 3 different ice cream flavors. You might have a different ice cream flavor. I might have a different one. You might like vanilla for a little bit and then decide that you like chocolate better. So it's a little bit trial and error, what works best for each patient.
One thing that comes up with Avastin occasionally is that it's not FDA approved for macular degeneration, and people think, because it's FDA approved for cancer, that how can you use a drug that's not FDA approved for macular degeneration?
Yeah, there's a lot of medications in medicine that we use off-label, so that aren't necessarily tested for that purpose. Most of drugs in pediatrics didn't have studies in kids. So even though something wasn't distinctly FDA approved, it does have a really excellent track record. So it's been used since the beginning of injections, which is probably 2005, 2006. So it's been around and has been used longer than some of these newer medications.
So they use it in small amounts too. It's not like as if you're using
Correct.
it at the same dose. Right. And there's a special classification by the FDA for off-label use, right?
Right.
That's a special FDA classification. Okay, good. Excuse me. Trying to remember what I said about leaving the questions till the end. May not work. Okay. So somebody asked if you're legally blind, would you continue treatment to preserve peripheral vision, or is peripheral vision not affected by macular degeneration as they tell us?
Even in advanced cases of macular, it's exceedingly rare to have any peripheral involvement. So typically, that you can't see the center, but you can see off to the side. So most people, even if they're legally blind from macular degeneration, they're not walking into things. They don't need seeing eye dogs. They just need magnification to help to see and to use that damaged center of the vision. Mm-hmm. There are rare cases where the bad blood is so active that you could lose an eye from it. But in general, if people have a lot of scarring in the central vision, that's usually end stage. And treating that might prevent it from getting slightly bigger, that blind spot. But in reality, I don't think it makes a huge difference for most people. Even if we stop injections, we tend to follow patients. And if it looked like off of the injection, you were one of these people that the blood vessels are very active, then we might advocate doing maintenance injections, even if the vision.
Oh, that definitely is important, that you follow up patients for the rest of their lives, right? Pretty much. If yeah, okay. Let's talk about scarring. Why does scarring occur? And well, why does scarring occur?
So typically, one of the common reasons why scarring occurs is because if you bleed from macular degeneration, the blood is toxic to the retina. So it can cause damage to those delicate outer layers of the retina, the photoreceptors, and you can get scarring in there. Other times, the dry macular component, the geographic atrophy, can still progress even if the wet macula is being managed.
Okay, good. There's nothing you can do about scarring, though.
Unfortunately, not right now. In the past, they used to try to do studies, subretinal surgery, to actually remove the bad blood vessels, or, scar tissue. And because the retina is so delicate, nothing like that.
Okay. Susan asks, when one RS decides that medication, the injections aren't working, could they be resumed by another retinal specialist? I guess that boils down to...
In theory, I could...
You can switch retinal specialists, right? That's not an issue.
Sure, you can switch retinal specialists, and there are times when, even if I don't think that it's going to make a big difference in someone's vision, they prefer to continue the injections because of that maybe slim possibility that it decreases the size of their blind spot or decreases the risk of damage. So I think that one retina specialist saying no doesn't necessarily mean that another one wouldn't say yes.
Yeah. Okay. Back to the Avastin, Sharon asks, is the Avastin absorbed systemically? And because it's used for cancer, is there any decrease in a person's immunity by using Avastin?
All of the medications are injected in a very tiny dose, and almost none gets in the bloodstream. Not 100%, but very little gets in the bloodstream. It's the same class of medications as Lucentis, anti-VEGF. It's just a slightly different molecule for Lucentis and Eylea. None of them are known to decrease systemic immunity. And in theory, even if it did, all of them are the same class of medications. But the way they work in cancer treatment, so Avastin is used systemically for colon cancer. So if you can imagine a colon cancer is fed by abnormal blood vessels, what it does is it shrinks up the bad blood vessels that feed the cancer. So it's not like it suppresses your immune system like a therapy.
Okay, good. How do retinal specialists decide how often to do injections? Because we have some people go in monthly, some go in every other month, somebody 6 months.
Most of the time, what we like to do, again, think about the analogy of these bad blood vessels are like weeds. When the weeds are very active, we like to inject monthly. All the studies, they usually do 3 monthly. So here's my hand model. But when the weeds are very active, you're going to keep getting an injection month after month after month until they quiet down. When they quiet down and we don't see signs of fluid underneath the retina or in the retina, then we'll try to space it less. So that's when we usually do what's called treat and extend. We see you every visit, but we extend out how often we see you. So then we'll go from 6 weeks to 8 weeks, 10, 12 weeks. Sometimes we try to stop it. Sometimes we don't. Again, that's retina specialist preference. My preference actually tends to be patients with good vision continue it at some interval, even if it's every 3 to 4 months long standing, because of this risk of recurrence. They are doing research to try to identify the people that can be off the medications and stay off those medications. But since we don't have that information yet, my preference is to at least get to the point where we're doing it only every 3 to 4 months.
Mm-hmm.
But not everyone can do that. Some people, if you stretch them out, fluid may recur at 7 weeks or 8 weeks, and then you can't go past that. And certainly some of my patients have it monthly, unfortunately.
So you would call the initial treatment every month or so like a loading dose? Is that the term?
Mm-hmm.
And then
you know,
then you described treat and extend. Isn't there another pattern which would be PRN as needed?
Yeah, some people do PRN dosing where you scan and you only inject if there's fluid underneath the retina.
Mm-hmm.
I think that is a valid way to do it. In my disclaimer is that I don't do it that way. The reason is because those bad blood vessels could become very active very quickly. And so I would prefer to stay on top of it rather than give those bad blood vessels a chance to really flourish and all of a sudden cause a big bleed in the vision.
Would somebody know if between appointments, would somebody know if they had a bleed, or should somebody with wet AMD call their doctor when they have any kind of change in their symptoms?
A patient with macular degeneration should definitely call the doctor if there's any change in symptoms. The other thing is that we are two-eyed people, so most people aren't covering one eye and looking through each eye independently often. That's why it is important to look at the grid, because if changes were happening in your non-dominant eye, you may not realize it until the changes are actually quite advanced. There are times when we notice a conversion to wet macular and patients don't notice it, which is again why we regularly follow patients.
Okay, good. All right. And then the whole procedure. So the eye is numbed, but some doctors use the numbing medication on a cotton swab and some inject a numbing medication. Why one or the other? Any better than?
They've done studies, and in theory, they're all supposed to be equivalent. Using drops, holding, a cotton soaked applicator at the site, doing subconjunctival lidocaine, or using lidocaine gel. They all, in theory, should be equivalent. And it's funny that sometimes it's just patient preference or retina specialist preference.
And the big one is, why do they have to use betadine? It burns my eye. Isn't there some other option for disinfecting? You're smiling.
Yeah, betadine is really the retina's best friend and worst enemy, and the patient, of course, the same. So everyone, as we're kind of touching upon, does injections slightly differently in terms of how often they like to do it, what numbing agent they use. The standard thing that all retina specialists do is betadine, because betadine is the one thing that's proven to help decrease the risk of infection. The risk of infection with the betadine is pretty slim. It's about 1 in 5,000. But anecdotally, I have certainly heard of people who haven't gotten betadine and their risk of infection goes up significantly. So that's why we do it. But betadine, the way I explain it to people is that it's a little bit acidic. So imagine squirting lemon juice in your eye. It can burn, it can tear, it can be really irritated. Definitely, if your eye is dry at baseline, you'll feel that betadine more. So some patients, I have them use artificial tears in advance to lubricate the front of the eye. We always try to rinse it out afterwards. And then there are some ways that we can try to help to make it not as bad afterwards. I have some patients that need to get an ointment in their eye, either a thick gel ointment or an antibiotic ointment to help cut down on that irritation. Others, I'll prescribe a drop that's kind of like Motrin for the eye to cut down on the burning and the pain. But I highly, even in people that say that they have an allergy to betadine, we're really hesitant to not use it because of the infection.
Is it actually an allergy or basically, because there's a, I guess, can there be an allergy, or is that just some people interpreting the burning as having an allergy?
Most of the time, it's actually a adverse reaction to it, like the burning and the irritation from it. There are people that don't believe that there's a true allergy to betadine, but I have heard about people anecdotally saying that they do get like a rash and things like that, which would be more concerning for the drug.
Yeah. And what about, so the idea, your idea is to, especially somebody who has dry eyes to going in, should use lubricating drops before the injection. And then you rinse out the eyes. You have somebody rinse out the eyes thoroughly, and then they should go home and rinse out the eyes thoroughly. Right?
I don't often have them rinse out their eyes when they're at home. We'll usually give them some artificial tears or some of these other drops and things. Sometimes you can actually, because you're so numb, scratch the eye, or sometimes the speculum can scratch the eye. So typically, if it's really add non-steroidal anti-inflammatory drop, sometimes I'll patch the eye if people feel like it's really bad. But usually there's ways to make it manageable. So if you have a lot of burning, definitely discuss it with your retina specialist, how to make it better.
Yeah, I didn't mean rinse out like, you know, old-fashioned rinsing out the eye with an eye cup. I meant artificial tears. Oh, by the way, I do know, Susan, I know we are having some voice dropping out and some screen freezing. Unfortunately, I think that's from the fact that we're all on different systems. You know, some of what's happening is on Facebook's ends. It could be my transmission, Dr. Barbera is yours, whatever. So we'll just soldier on. All right. Oh, and the big, how do I come out of there with a big red bloody eye? How does that happen?
So just like when you get blood drawn, sometimes you get a bruise and sometimes you don't. That's what I tell people. So we always try to avoid the big obvious vessels on the white of the eye, the sclera or the conjunctiva, but sometimes unfortunately you nick one. It is definitely more common if you're on a blood thinner, aspirin, Xarelto, Plavix, but it can happen to anyone. It's really just cosmetic. It looks very, very scary and very bad. Sometimes it's a little uncomfortable because, you know, you're not used to having a little bit of blood under the skin of the eye, but it's really just cosmetic. And most of the time it will fade in a week. If it's a really bad bleed, it can be 2 weeks. But it looks a lot worse than it is.
Mm-hmm. And speaking of medications, you mentioned the red eye may be more prevalent in those who take blood thinners. The question is, those people who take blood thinners, or should people take blood thinners if they have wet AMD? Is taking a blood thinner like aspirin or the other ones going to make the wet AMD worse?
Taking a blood thinner doesn't make wet macular degeneration worse. You're no more likely to have a big bleed in your eye, like that. So it wouldn't. I would definitely take the blood thinner if you need it for other systemic reasons.
Are there any medications that somebody with wet AMD should avoid? Or any vitamins?
In general, no.
Okay.
In general, I think that, no, I mean, smokers definitely get worse, so avoid smoking. I think in general, you can extrapolate that smoking is putting a toxin in your body. And so in general, you know, a healthy diet, not putting toxins into your body. So a healthy diet probably plays a role into that as well.
Speaking of a healthy diet, okay, so you're saying that not putting toxins into your body through diet is a good idea, but what about the traditional eye healthy diet? Can it help with wet AMD?
So I try not to, I personally don't necessarily recommend any specific sort of for patients. I think that there's an absence of large randomized controlled trials in a lot of things. And I also do unfortunately think that a lot of companies will a little bit prey on patients that have eye problems and macular degeneration. Every now and then you'll see studies on things like, you know, saffron helping or, you know, things like that. In general, I don't really recommend any distinct diet modifications or diet plans myself. But I know others do. It's just that there's not huge controlled studies in anything besides the AREDS vitamins.
And speaking of the AREDS vitamins, do you recommend that your patients with wet AMD continue to take or start taking an AREDS2-based supplement?
I typically do if there's a possibility, because there's a possibility of geographic atrophy. However, if they have advanced scars in both eyes, then there's probably less, you know, efficacy or reason to really take it. The data with the AREDS vitamin is really only 1 in every 4 people. Does it slow the progression 5 years? It's not the greatest data. So if there's a compelling reason, like it really upsets people's stomach, they are very expensive. I may not necessarily really stress to patients that they have to take them.
And as far as, of course, if somebody has one eye wet and one eye dry, the data from the ARED studies does show that it gives some protection to the dry eye, right? Is that your interpretation?
Yeah.
Okay. There's a big controversy about that, of course. So, all right. Let's see.
I read the group, and it is true that up at our big meetings, we'll have very well-known retina specialists debate each other specific formula within vitamins. So it is a debated topic even among us.
I believe you. I have heard many stories from conferences, and I've read some of the, you know, the correspondence and the white papers and the editorials and whatever. And it, you know, from my understanding, it started in 2001 when the first AREDS data was released, and then, you know, in 2013, it just continued. So thank you for confirming that. You said debated. Do the debates get, yeah, they get a little heated?
I think they're all professional, but they're very passionate about their business. I'll say that.
Yeah. Okay. There we go. They're passionate. That I've seen. Okay. Let's see. Some people have injections and their vision improves, and some people don't. What's the story on that?
The biggest factor tends to be what their presenting vision is. So sometimes by the time people are diagnosed, have a significant bleeding, again, blood is toxic to the retina, or scarring. And so even if you can shut down the choroidal vascularization, this bad blood vessel, sometimes left with the residual damage from it.
Mm-hmm. So not everybody gets vision improvement, right?
Correct. Yeah. In initial trials, they said about 90% of people either improved or stabilized. So in most cases, it's still, if you weren't getting them, you'd get worse than what you are now. So even if people don't see a huge improvement in vision, unless the vision's pretty poor, I generally do continue them.
Dr. Legg talked to us about the importance of early detection of wet and the studies that showed that the initial visual acuity is usually the same 2 years later, which means that if you get it early and your visual acuity is still good, 2 years later, it's going to continue to be good. Is that correct?
Yes, in general, that is true. One of the reasons why I prefer to do the treat and extend versus the as needed treatment dosing is that my interpretation of the data tends to be that under treatment can be a reason for slip vision over the years.
Yeah. Okay. Susan asks, when you're given an injection, is there a standard dose, or do you change the doses of the medication for any reason?
There's standard doses of all of the drugs. So some people, in general, yes, there's standard doses. Some people, there are retina specialists around the country who may play with the dose and inject a little bit more. But in general, all the studies were on a standard dose. Eylea, 2 milligrams, Lucentis is 0.5 milligrams. It's a different dosing for diabetics. Avastin, it's 1.25 milligrams. So they are pretty standard.
Okay. Now, why do some people get black dots or spots, floaters after an injection?
Yeah, in general, the floaters they can have might be two things, or a few things. One is that some people will say that the medication itself they see almost like a lava lamp when it goes. Yeah. The viscosity of the medication is different than inside your eye, and so part of that is what you see. Other times you can have air bubbles in the syringes. You'll often hear your retina specialist kind of messing with or to try to get those air bubbles out. But if you have distinct circular floaters that are down below, those tend to be air bubbles. Your brain actually flips everything down and backwards, so the bubble's actually up top in your eye, but you see it down below. Those usually go away in a day or two. We always tell people to look out for a sudden onset of new flashes or floaters, which could indicate that the gel of the eye is separating from the retina. If that's the case, which is a little bit more like with shots, you would just want to let your retina specialist know to make sure there's no holes.
After an injection, they see some spots, dots, floaters. They should just dissipate, but if it continues, and if they have flashes or floaters, they should talk to the retinal specialist.
Yeah, so in general, I'd say everything should pretty much get back to normal after about a day or two, or at least be getting significantly better. If anything is getting a lot worse or persisting, then call your retina specialist.
Boy, am I getting a lot of dropout as we continue. Are you getting that, Dr. Barbera? Yeah. Oh, Lord.
Oh, yeah.
We may have to go back to Zoom in the future. Anyway, let me think. So, why after an injection, some people get their eyes actually hurt. Is that what causes that? Not enough numbing medication, or it wears off, or?
Often I still think it's related to the betadine, that people do feel like there's soreness because their cornea is irritated, and the cornea has a lot of nerve endings. So typically I still blame the betadine in that case. I do have patients that really complain of pain, and those people, that Motrin drop that I was talking about, like Cataract, Prolenza, a non-steroidal anti-inflammatory, sometimes helps a whole lot.
So that's a prescription medication, the topical Motrin. Okay, that's good.
Right.
Some people say they get cornea scratches. Is that basically from the speculum?
It can even just be from the betadine, kind of harming the cornea.
Whoa.
It could be, but yes, it's more likely with the speculum, because sometimes the speculum rub up against it, or sometimes patients aren't aware themselves too with a pretty numb eye.
Yeah. Okay. In the case of a scratched cornea, there are treatments for that if it's a big problem.
Yeah, if really anything is out of the ordinary, the pain is really severe, then I would call your retina specialist. And sometimes patients do come back with an abrasion, and we'll give them ointment or patch them or something like that to make it get better.
We have some of our members who really don't want to call their doctors when they have any of these problems. They think they're bothering them, and that's very considerate, but it's your eye, and so you need to do that. I mean, if you're still having problems after the injection, call, right?
Yeah, we would all rather we hear from you and, you know, we tell you if something is something to be worried about or not, versus you miss a symptom that is something that you really should avoid, that we should have seen you about, like a sign of an infection, things like that.
Yeah, yeah. When will there be eye drops for, do you think we'll ever see eye drops for wet AMD?
They've definitely tried to study eye drops. Unfortunately, the way the eye is, it doesn't penetrate very well back to where those bad blood vessels are. So right now, as the technology stands, there's good treatment for it. But, you know, if you think these injections weren't around 25 years ago, we've really made huge headways into our treatment of macular, and it may be in the future, but not yet.
Yeah, yeah. Brian asks if cod liver oil useful for dry AMD, and you're not a ophthalmologist or anything, but you're a retinal specialist. But what's your thought on cod liver oil for dry AMD? Wait, dry
part
AMD.
Ooh. Was that they looked at like DHA and some of these fish oil type things, and they didn't show any additional benefit.
But for dry eyes, omega-3s are supposed to help.
For dry eyes, yeah, they tend to have to help with dry eyes.
All right. Some people get confused with dry eyes, which is a different disorder, and dry AMD. Okay.
Yeah, it's very poor name.
Let's see. Sherry says, injections might help with vision improvements in some patients, but is it also valuable to help maintain the vision? Or if you don't get improvement, at least you can maintain it.
Yes. As I was saying, with the initial studies, 90% of people either improve or stabilize, whereas the natural course of macular is that things do get worse and you lose that central vision. So even if you don't see a significant improvement, typically it's helpful to continue to prevent vision loss.
Mm-hmm. Speaking of that, I don't know if I'm pronouncing it correctly. Beovu? What is it?
Beovu.
Beovu. Okay. Beovu, the clinical trials show pretty nice vision improvement, but are they taking it off of the market because of the inflammatory issues? Some of my, at least one of my members said that her doctor said they were going to pull it.
I don't think they've pulled it just yet. They have pulled their sales team, and they're not marketing and investing a lot in it. So I'd be surprised if it does. But what happened with the Beovu is clinically they showed greater durability, greater drying effect. Unfortunately, when it hit the real world, there was a degree of inflammation that hadn't been seen in the previous injections of Avastin, Lucentis, or Eylea. So whereas retina specialists were very excited about it, most have stopped using it. I do have people that are continuing to use it in cases that respond really well.
Susan asks, if you have a large number of shots in any eye over the years, does it contribute to more scarring damage and vision loss in addition to what's going on with the disease process?
It generally doesn't. It kind of prevents it. You have more scarring when these bad blood vessels are very active, and especially when they bleed. So that's not really a concern. There have been people that have been getting injections since the start of 2005-2006 on a regular basis.
Yeah, yeah. We have members who've had them for many, many years. And what about the recently FDA approved, let's see if I can pronounce this right, Susvimo?
I also think that's the pronunciation. So Susvimo is a reservoir that is surgically implanted in the white of the eye. It has enough to last longer. So the initial thoughts are that most people can go 6 months, and then it's refilled in the office. So in theory, it sounds very promising for those patients that need to have a monthly injection in order to maintain control of their wet macular. It's one of those things that certain people are doing. There's always your early adopters and your people that hold back and wait a little bit. The surgical technique, even in the study, they've refined it a little bit because there was some risk of bleeding in it. And the one thing is that the risk of infection with injections is very, very low. And because it's an actual surgical procedure, they're seeing very slight increase in the risk of infection, but it's still a low number. So I think it's a very great option for people that are dependent on monthly injections to give them sustained amount of medication in their eye.
Will you be using it?
I tend to be a later adopter. So right now I haven't done any, but I certainly think it's a good option for a lot of patients. The medication in Susvimo is Lucentis. So the perfect patient would be someone that needs Lucentis every month. If you're on Eylea every month or Avastin every month, it's probably better to make sure that Lucentis does just the same for you before getting the system.
So you would have, you would have injections of Eylea before trying the Susvimo.
The Lucentis, yeah. So you'd want to make sure that the patient is Lucentis.
Oh, yeah, I got it. Okay, let's see. I'm getting down to the bottom of the list, I think. So if you're watching and you have any burning questions, you better type them soon. And the new injectable medication, the
Vabysmo. I don't know who names these. I'm sure there's focus groups. I think it's Vabysmo, but it's the first medication that targets 2 medications in the angiogenesis cascades that helps to shrink up bad blood vessels. So again, there is a lot of initial promising results from it that maybe that's a medication that might have a more sustained response. Maybe you'd be able to get an injection every 3 or 4 months instead of every 1 or 2 months. I think, again, just like Beovu, we were all very excited at the beginning, but I think everyone is more wait and see how it performs in the real world first. That's my take on it. But I think it does sound very promising. You have to remember that when Beovu came out, the thought that was, not when Beovu came out, when Eylea came out, they were marketed as do 3 monthly and then go right to every 8-week dosing. But in practicality, we don't really do that. We do that the same we do the same as the other medications, go monthly and then kind of extend out and see what we can do. And I think that's what's going to happen with the Vabysmo. We'll try to increase the interval and see how well people can do with it.
Okay. Is there anything in the pipeline you're looking forward to?
I think everyone recognizes that in dry macular degeneration, geographic atrophy is a huge area, an unmet need. It's frustrating.
Yeah.
They come in, they're getting worse, and there's nothing we can really do. So they're doing research into stem cells or gene therapy. Is there a way, maybe something could be put in the eye or injected even that helps to prevent geographic atrophy or help reverse it. That's all very theoretical research or in those early stages right now. That would be great for retina specialists.
Yeah. Well, the logical thing, and there was a discussion recently, why is there nothing in the early or intermediate stages to, stop the disease there so it wouldn't, well, that would put you out of business.
I would be happy.
You have other things to do. You have other things you do.
I think that we're all in the business of helping people see better forever, and we would be happy if we could stop it.
So why don't we see anything coming through as far as?
Yeah, they've tried certain things. They've gotten a little bit of success, but I think part of it is just that macular degeneration is so multifactorial, whereas, you know, dry macular degeneration, whereas when you look at wet macular, they've kind of honed in on this one molecule that is the source of the bad blood vessels growing. So I think that's part of the problem.
Yeah. Jean, she did talk about why some people start with Lucentis instead of Eylea, and I'll rephrase it and she can, or I'll repeat it and she can confirm if I've got it right. Sometimes it's just a matter of the insurance. Is that correct?
Yeah, a lot of times, actually more and more, especially in 2022, we're having a lot more insurances say you must start with Avastin. I touched upon before, Avastin medication is compounded, so it ends up being cheaper overall for insurance companies and everything. So it's very frustrating. But some patients, even if they're not doing well on Avastin, the insurances will say you have to do 3 or 4 before you can go on to another. That's called step therapy. And the Academy, American Society of Retina Specialists, or the Cataract, to fight policies like that, because they're all proven to have efficacy, and it really should be the doctor's feeling of what's best for the patient.
Jean, that's perfectly okay. It doesn't matter that if you came in late. We started late because we had some technical problems, so don't worry about that. All right, let me see. I'm at the end of my list. Does anybody have any other questions? Thank you. You have answered every single one so well. I apologize for the technical difficulties. And as far as it goes with technical difficulties, I'm continuing. I've been recording this on Zoom on my laptop. Fingers crossed, it's storing it on my computer. So there's been a lot of dropouts. Some of you have said that the computers are frozen, there's no audio. You'll be able to watch this, I hope, all of this stuff. And before I do this, I'll have to figure out the best way. So
I did as I kind of touched upon my answers, it is really individualized. So I would certainly take your concerns to your retina specialist and kind of talk about your individual case, because not everything may be applicable to you. And I think that 25 years ago, it was a terrible time to have wet macular. You would lose central vision, you would lose your ability to drive and your independence. And now a lot of times with these new treatments, you can continue to live a full life and stay independent. So I just kind of want to remind you to continue to have hope, that there are lots of good treatments and a lot of smart people around the world that are working on even better treatments for others.
I agree. Had way of the engines, and they used lasers, and he lost good tissue because of it, and lost his central vision. There wasn't much. So, okay, great. And we have some thank yous coming through. Thank you.
Thank you.
Thank you. Dr. Enla, thank you so much. Thank you. And
you're very welcome.
Thanks to the audience for your patience. I'll get this. One of these days, we're on, I think this is the 6th, 7th. I got to get right soon. So, hey, thanks anybody.
All right.
All right.
Take care. Thank you. You're welcome.
Thank you very much. Bye-bye. Bye, everybody. Bye.